This is a short history of psychiatry, mainly American psychiatry, and mainly outpatient or office psychiatry, not inpatient or hospital psychiatry. Any of these topics could be long videos or articles of their own, but here I'm aiming to give you an overview. How psychiatry started in insane asylums, how it evolved into an office-based practice, and the ongoing tension between biology and psychology in my field. By the end, you'll see why psychiatry has a lot of battle scars over the years, but may be finally headed to a better place. I'm Dr. Stephen Reidbord, a psychiatrist and psychiatric educator, and I have a long history of my own. If you like what I'm doing here, please like this video and subscribe to More Than Meds. Psychiatry is a lot older than Sigmund Freud, who wasn't even a psychiatrist. We'll get to that in a minute. The German physician Johann Christian Riehl in 1808 coined the term psychiatry, in German of course, establishing it as its own medical specialty. For the first century of its existence, basically the 1800s, psychiatry concerned itself with severely disordered patients, people in hospitals or insane asylums who couldn't function in everyday society. These patients were generally psychotic or manic or severely depressed or demented. As we would look at these cases now, many of them actually didn't even have psychiatric problems. Many had brain tumors or metabolic or glandular disorders. They may have had syphilis that affected the brain, seizure disorders. But at the time, no one knew the difference. If a person acted bizarrely and was out of touch with reality, that was that. Over the course of the 1800s, psychiatric care progressed from basically custodial care, housing the insane in institutions, often in inhumane conditions, to what was termed moral treatment, which emphasized humane treatment, fewer restraints, although they still restrained the patients, structured daily activities, and some individual attention. All the same, as we would look at it, we'd still consider it cruel treatment. Like the rest of medicine in the 1800s, treatment was crude and not particularly effective. People with mental health problems who could function in everyday society were not treated by psychiatrists. Instead, they were treated by neurologists, physicians who specialized in nerve problems, and who treated nervous conditions named for their presumed origin in the nervous system. That's why we have terms like nervous breakdown or someone who gets on your nerves. In the mid to late 1800s, the French neurologist Charcot and his student Janet studied patients with hysteria, we'd call that something else nowadays, in the hospital in Paris called the Salpêtrière. They used hypnosis, and they introduced the ideas of dissociation and the subconscious. Then, based in part on their work, a neurologist in Vienna, Austria, by the name of Sigmund Freud, you knew we'd get to him eventually, right? Published theories on the unconscious roots of some of these problems that he and his fellow neurologists were treating. He called these problems psychoneuroses. These were apparently neurological problems that were caused in psychological ways. The term psychoneurosis was later shortened to neurosis. The disorders that Freud called neuroses impaired everyday functioning, particularly interpersonal relationships and activities of everyday life, and sometimes produced odd symptoms like paralysis or an inability to speak that couldn't be explained medically. Freud developed psychoanalysis to treat these neurotic patients. Psychoanalysis was a very intensive psychological treatment that involved having the patient lie on a couch and free associate, say whatever comes to mind, while the analyst would listen carefully for symbolic and hidden meanings in what the patient was saying. This took place in 50-minute sessions 6 days a week when Freud was doing it, although over the years it's decreased down to about 4 times a week these days. In an interesting historical twist, psychoanalysis became a practice of psychiatrists, not neurologists. And so psychoanalysis became the first outpatient treatment in our field. Freud and his followers didn't have much to say about severe mental illness like psychosis and mania. So despite a gradual acceptance of psychoanalysis in outpatient treatment, psychiatric patients in the hospital, inpatients, still were treated with insulin shock treatment, chemical convulsions, later electroconvulsive therapy, hot and cold water hydrotherapy, occupational and work therapies, various kinds of restraint, padded cells, straitjackets, sedatives, and sometimes lobotomies, crude brain surgery. Now, I'm not a psychoanalyst myself, but elsewhere on this channel, you'll see a lot of information about psychodynamic psychotherapy, which is an offshoot of psychoanalysis based on similar ideas and approaches. That's the kind of therapy I provide in my own practice, so check that out if you're interested. Biological or bodily treatments for psychiatric inpatients with severe disorders and psychoanalysis and similar psychotherapies for patients who live everyday lives but are troubled psychologically and emotionally, created a split in the field, which continues to this day, between the biological and the psychological. Psychoanalysis was the dominant paradigm in psychiatry in the first half of the 20th century. And like many dominant paradigms, we can look back and say that it overreached. It was extended to areas where it really didn't belong. It was employed for conditions where it didn't seem to do much good. Problems that we'd now identify as autism or PTSD or ADHD or obsessive-compulsive disorder, OCD, none of which we now know is helped very much by psychoanalysis. Also, over the years, psychoanalysis started to be used in the hospital as well, with more severely disturbed patients with, say, schizophrenia or mania. And this led to some creative but basically misguided ideas about how these problems were caused by bad mothers and bad mothering, which we now know isn't true. And of course, psychoanalysis didn't work at all for the medical problems that were also not recognized in those years, brain tumors and neurosyphilis and so forth. During the heyday of psychoanalysis, basically the first half of the 20th century, experimental evidence of its efficacy, its effectiveness was scarce. Psychoanalysts mostly avoided doing experiments. They really preferred detailed single case studies, as Freud had made famous. Also, psychoanalysis and similar therapies are inherently hard to study experimentally. Imagine trying to standardize a treatment that's specifically designed to be unique for every patient. Nonetheless, many case reports allege the benefits of psychoanalysis, and in the years since, there has been empirical research that supports the idea that psychoanalysis and related psychotherapies are effective for selected types of emotional problems. But psychiatry changed in the middle of the 20th century, around the 1950s and 1960s. There were big discoveries in medications to treat mental illness. The first antipsychotic medications came out in the late 1950s. Thorazine and other first-generation antipsychotics, also called neuroleptics, really changed the symptom picture of patients who were previously confined in hospitals. The first antidepressants also came out around that time, around 1960. And they helped severely depressed patients when previously only shock treatment could help before. A little later, around 1970, lithium was introduced in the United States for mania. All of these medications led to dramatic changes in the ability to treat patients outside of hospital settings. Patients with schizophrenia or manic depression, what we now call bipolar disorder, could be treated out in the community, whereas previously they were kept in hospitals, sometimes for most of their lives. State mental hospitals rapidly emptied out at that point in history. It was called the deinstitutionalization movement. These patients who had been institutionalized no longer needed to be. The idea was that all of these folks would be treated out in the community in well-funded community mental health clinics. Now, as you may know, it didn't really materialize that way. The community mental health system was never funded in the generous way that had been pictured. And that, in short, helps to explain why we have so many mentally ill people on the street, homeless, not being taken care of very well. In any case, psychiatric patients with various degrees of symptoms were now being treated out in the community. So this was a major shift in psychiatric care and practice, with a much greater focus on medications, heavily promoted by drug companies. The Rolling Stones immortalized the tranquilizer Valium in their 1966 song, Mother's Little Helper. And Valium went on to become the biggest selling prescription medicine in the United States in the 1970s. For many patients, these medications were quite helpful. The antidepressants helped a great number of patients, particularly when used with fairly severe as opposed to mild depression. The antipsychotic medicines, although they were largely sedating, did seem to address the major symptoms of psychosis. And there became a growing acceptance that psychiatry was becoming a biological specialty of medicine. In the late 1960s, the civil rights movement was extended to psychiatric patients. And laws were passed, starting in California and eventually to the rest of the country, that restricted the forced hospitalization of psychiatric patients. Before that, patients were confined and treated based on a psychiatrist's assessment that they would benefit by such treatment. But these laws, when passed, restricted involuntary psychiatric hospitalization to dangerousness. The patient had to be suicidal or dangerous to others. That meant that even severely disturbed patients who might benefit from inpatient care often refused treatment if they weren't dangerous. In 1980, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association, or the APA, was radically revised. This new edition, DSM-III, it was called, in 1980, defined mental disorders not according to psychoanalytic principles, which was true in the first two editions. Instead, it avoided any theories about psychiatric etiology, the cause of psychiatric disorders. If you met criteria for a particular disorder, if you fulfilled enough symptoms that defined that disorder, then you would be diagnosed with that disorder. This was done to provide a common language for the biological psychiatrists and the psychoanalysts, and also to improve inter-rater reliability in psychiatric diagnosis. One result was that psychoanalysis and similar therapies were soon seen as vague and unscientific, which was kind of the point of the revision of the DSM in 1980. Meanwhile, pharmaceutical research took off in pursuit of medications that would treat discrete symptoms such that a patient would no longer fulfill criteria for a DSM-III diagnosis. The push for drug innovation paid off. A new class of antidepressants called the SSRIs were less dangerous and more easily tolerated than prior antidepressants. The first of these, Prozac, was released in 1987. Soon after, new antipsychotics were released, the so-called atypical neuroleptics like Risperdal and Zyprexa. Heavily promoted and with apparent advantages over what came before, these medicines were widely prescribed by psychiatrists and soon by primary care doctors and others. Psychiatry was increasingly seen as a mainstream medical specialty, and lots of research dollars and research efforts were shifted towards biological treatments for mental illness. The National Institute of Mental Health, the NIMH, declared the 1990s the decade of the brain to enhance public awareness of the benefits of brain research. The fourth edition of the DSM was published in 1994, further expanding psychiatric diagnosis based on concrete criteria that could be treated with medication. Biological psychiatry seemed to have triumphed over psychoanalysis. Meanwhile, on the psychotherapy side, psychologists and some psychiatrists like Aaron Beck popularized the use of cognitive and cognitive behavioral therapies. These symptom-focused approaches were much easier to study than psychoanalysis and its offshoots. They featured concrete, easily replicated interventions, often from a manual. So there were soon a large number of empirical studies showing that CBT could reduce the symptoms of depression and anxiety, such that patients no longer met DSM criteria for those diagnoses. This empiricism, this idea that it's only real if you can measure it, meshed very well with the evidence-based medicine movement of the 1990s. Basically, a reminder to physicians in general to pay attention to the research in their field and not to rely on anecdotes. Whether treated by a psychiatrist with a prescription pad or a psychologist with a CBT manual, emotional difficulties were first categorized according to DSM criteria, DSM-IV in this era, and then treated by sharply focusing on the defining symptoms that made up that diagnosis. The feeling in psychiatry was that we were going to become a neurobiological specialty, that psychiatry through brain imaging, brain research, genetic studies, and so forth would gain the same underpinnings as other specialties of medicine. This was reassuring to a lot of psychiatrists because we've always been the odd specialty in medicine. We've always been the one with the separate building across the street from the main hospital. We're part of medicine and kind of not part of medicine too. As a result, there was a lot of effort by the American Psychiatric Association, the APA, and other psychiatric organizations to establish psychiatry as a biological specialty. Unfortunately, this was also an overreach in much the same way that psychoanalysis had been decades earlier. Despite the decade of the brain and tremendous amount of money spent on biological research, not much changed in the treatment of psychiatric patients. Here's a quote from the former head of NIMH, Dr. Thomas Insel.
I don't think so. No, 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 no. Maybe someday you'll have it your way. Maybe someday.
Pharmaceutical innovation dried up in the 2000s. There were no new blockbuster medications, no new big insights about treating psychiatric disorders. Previously unrecognized or underappreciated side effects of psychiatric medicines began to hit the headlines. The SSRI antidepressants were identified as increasing suicide risk in some populations. They got a black box warning. Some patients reported severe discontinuation syndromes when stopping psychiatric treatments. The atypical neuroleptics were associated with a metabolic syndrome of increased weight gain, increased diabetes risk, and other medical complications. Basic brain research taught us a lot, but led to no big insights in to help us understand the origin of psychiatric disorders, nor to novel biological treatments. And then to top it off, pharmaceutical companies were repeatedly fined for huge sums of money for promoting these medicines in unapproved ways and for unapproved uses. It's also important to emphasize that medications often don't address the actual problem that patients present with, that the person's actually suffering. Treating depression with an antidepressant medication may not get to the root of what's causing the depression if it's psychological. And in that case, the depression will come back. Same for anxiety, the same for lots of problems that people come to see mental health professionals for. This is especially true for interpersonal problems and personality issues, for lack of meaning in life, for problems with a person's self-identity. None of these have medication treatments. The current revision of the DSM, DSM-III, was released 12 years ago in 2013. It stirred up a lot of controversy at the time for its medical biological bias, for further restricting the range of what we consider psychologically normal, and for continuing to categorize personalities, having this personality or that personality, as opposed to looking at personality dimensionally. You have more of this and less of that, which has been the practice in psychology for generations. The NIMH announced that it would no longer use DSM diagnostic categories in its research because they weren't scientific enough. Even the chair of the task force that produced the DSM-IV criticized DSM-V. And so the history of psychiatry is that it began as the medical specialty for the hopeless and forgotten, for patients in insane asylums and state hospitals. Then the pendulum swung towards psychoanalysis, which was very helpful, but was applied in ways where it didn't belong. And then the pendulum swung in the other direction towards biological treatments, which also helped many people, but was overextended in areas where it didn't belong. In addition, the overuse of medications in psychiatry has led to a kind of devaluation of the field of psychiatry and psychiatric expertise. In many settings, psychiatrists have become vending machines for psychiatric medications, trying one after the other in a kind of trial and error fashion until something helps. I'm happy to say that the pendulum seems to be swinging back again at this point. Maybe it'll settle in a more stable place this time. For one thing, there's a growing recognition in psychiatry of the psychology of medication prescribing, taking into account placebo effects and also nocebo effects, that's the opposite of placebo, as well as the psychodynamics and complicated transference and countertransference enactments that can happen in a medication clinic. We're also beginning to pay attention to trauma and the social determinants of mental health, long overdue in mainstream psychiatry. This is the biopsychosocial model in action, taking the biological, the psychological, and the social determinants of well-being into account for a given patient. When we look through this wide-angle lens, a lot of emotional distress can't be reduced to DSM diagnostic categories. Medications can be very helpful, but they're just one tool among many. The interpersonal relationship with a caring psychiatrist or other mental health professional is at least as important as medications for many of the problems that people suffer from. We're beginning to appreciate the worth of such relationships at just the point that commodified corporate mental health care and AI chatbots threaten to snatch it away. The first thing we need to do is to connect as people, to get to know the person behind the symptoms, to understand where they're coming from and where their problems may have originated, what the context is. The future of psychiatry cannot be brainless or mindless. We still definitely need biological research. Over the history of psychiatry, there have been many examples of problems that were originally thought to be psychological or mental that turned out to be medical. Examples of that include dementia or seizures. We may in the future discover one or more medical causes of schizophrenia, for example. But at the same time, we are nowhere near close to understanding human psychology at a medical or neurological level. Even if the medical and the psychological distinction becomes less sharp in coming years, and it might, we still need to be and stay flexible to encompass the whole biopsychosocial spectrum. Individual psychiatrists may specialize in the biological or the psychological or the psychosocial, but the field as a whole needs to cover a very wide purview going forward, from the cellular basis of behavior to individual psychology, to family dynamics, and finally to community and social factors that affect us all. Want to watch another video of mine? Of course you do. Check out this one. Please subscribe and you'll be notified when my next video comes out. Thanks for watching. See you next time.